the first and the third Sundays of the month in multiple subspecialties. The purpose of this program is to share expertise and knowledge from the West to radiology folks who are interested. We want to thank IT team this year from Vietnam for taking care of the broadcast and recording. The steering committee from Indonesia for beautiful flyers and communicating with the member. I would like to remind you all that our next session will be next Sunday, not the following Sunday, the Sunday 14, which is this coming Sunday. It is MRI staging of cervical and endometrial cancer, FIGO classification with Dr. Surabi, who is from University of Texas MD Anderson Cancer Center in Houston, Texas. It will be next Sunday. And now I want to pass on this task to our moderator today, Dr. Dichan Pema from Bhutan. Dr. Pema, please.
Hello everyone, welcome to this session. I am Dr. Dichan Pema from Bhutan. I'm currently working as a radiologist specialized in breast imaging at the Jigme Dorji Wanchon National Referral Hospital in Thimphu, Bhutan. So today I am delighted to introduce Dr. Bowen Nui, our speaker for the session. Dr. Nui is currently an assistant professor in breast imaging at the Wake Forest University School of Medicine, Winston-Salem, North Carolina, US. And as a brief introduction to him, he graduated from the NYU School of Medicine in New York in 2017 and did his radiology residency at Wake Forest, graduating in 2022. He then did his fellowship in mammography in 2023 and has been pursuing an academic career as an assistant professor at that institution. So Dr. Bowen will be speaking on an introduction to breast MRI. So I invite Dr. Bowen to take the screen. Thank you.
Okay. Awesome. Well, thanks for the kind introduction, everyone. I'll just go ahead and get started then. So this talk is just going to be kind of an introduction to breast MRI. The four sections I've got planned for today is first, I'm going to talk about the indications for breast MRI. Then I'm going to go through the protocols and sequences for our studies. And then I'm going to also talk about the BI-RADS lexicon for breast MRI, aka how do we describe what we see on it. And then lastly, I'm going to go through some cases, and the cases are going to be showing some common pathologies that we see on breast MRI, what they look like, and then also some cases where breast MRI really added a lot of value to patient care. So just getting started with the indications. So the main thing about breast MRI is that it is the most sensitive examination we have. It is very costly. It does require a lot of time in the scanner. It's very uncomfortable for the patient, but the reason it is worth it is because it is the most sensitive exam for detecting breast cancer. But what comes with that means that you should select your patients very carefully because there are a lot of benign entities that show up on MRI as well. And so for a screening MRI, the common indication is a patient that is considered high risk. And so this is going to be a patient whose risk calculators, we use Tyrer-Cusack at Wake Forest. And basically, if the calculator comes up with a 20% lifetime risk or greater based on your personal or family history, and then, of course, there are all these mutations that automatically put you in that 20% lifetime risk category. I think many people are familiar with BRCA and Li-Fraumeni. Untested first-degree relatives of these carriers are also assumed to fall in this 20% risk category. And then patients who are 15 to 30 years after mantle field radiation therapy for lymphoma also will need screening breast MRIs. And then there is this gray area that the ACR, the American College of Radiology, describes as intermediate risk that may be appropriate for MRI. So that would be patients who fall into that 15 to 20% risk, patients with a personal history of breast cancer and breast tissue, and patients who have gotten breast cancer before the age of 50. And then breast MRI is also very useful in patients with known cancer. In this, some patients, especially patients with invasive lobular carcinoma or invasive ductal carcinoma with lobular features, a breast MRI is often used to make sure there's not multifocal or multifocal central disease, which can change surgical management. MRI can also help you see chest wall invasion, since it has probably the best anatomic coverage. And also, if you have positive or close margins on lumpectomy, a breast MRI can show enhancement near the lumpectomy site that could help you plan to go back in and take out any cancer you might have left behind. And then lastly, we also use breast MRI to follow patients getting neoadjuvant therapy. The measurements of a cancer on breast MRI are probably more accurate than on other modalities, especially for invasive lobular carcinoma. So our oncologists like to use the measurements on breast MRI to gauge response to neoadjuvant therapy. And then there are some other uses. The only we do breast MRIs without contrast. The only reason to do that is to evaluate breast implants, whether or not a silicone implant has ruptured. We're also very explicit that in a breast MRI without contrast does not look for cancer. Also, patients with suspected recurrence get a breast MRI. And then also we use breast MRI because it's very sensitive, it's also a very useful exam in a patient where you have a metastatic cancer of unknown origin or a suspected breast origin, like you have a bone lesion or a lymph node and the biopsy comes back with a breast origin. If their mammogram has been negative, the breast MRI is really our first step after that. And then also patients getting after a flap reconstruction surgery, MRI is very useful for assessing palpable areas of palpable concern in those patients. Moving on from indications, I'll talk a bit about our sequences and our protocol. So this is the protocol that our protocol for breast MRI with and without contrast. So patients are imaged prone, and we start with a T1 weighted pre-contrast image without FAT-SAT, and then we do a T1 weighted pre-contrast image with FAT-SAT, which helps us kind of determine if things are following fat. And then we do a T2 weighted stir. And then I also put here, I'm just kind of going in order with the images they send us. We do a diffusion weighted and ADC image, but we only really use this for research purposes. There's a study that uses the data. There is literature saying that this could be useful to do a non-contrast screening of breast MRI. It's still very theoretical in research. I think the field homogeneity we achieve really does not give us much diagnostic quality in these images. And then moving on to the meat of the study is going to be our T1 weighted dynamic post-contrast. So this is going to be T1 weighted. We use Vibe for FAT-SAT on our pre and post-contrast images. Basically, we do multiple post-contrast sequences 90 seconds apart. The number of post-contrast sequences kind of varies in our sites, but usually it's somewhere between 3 to 6 or 3 to 5 post-contrast images. And the reason for that is that dynamic enhancement it can be useful to gauge to inform your level of suspicion for malignancy, and I'll kind of go into looking at the dynamics and the kinetics in a later slide. And then with these, and we do all of these images in axial, and then we have specialized software to help us eliminate motion on the subtraction images. We look at all our post-contrast as a subtraction and also without subtraction. So Dynacad is our software to eliminate motion between the post-contrast and the pre-contrast images so that the subtraction is more accurate. It helps us reconstruct in additional planes, and also it's how we look at kinetics. For our slice thickness, we do 1 millimeter slice thickness and then a left to right phase and code direction, which gets the motion of the heart out of the way. And then we at our cancer center, we use an acquisition matrix that's basically wider transverse than instead of anterior posterior. This is basically just wanting to throw up a picture of a breast coil in case nobody's ever seen it. I think this might actually be a setup that can also be used for biopsy, but basically the patient lies prone on this table. Their face kind of rests in this cushion here, and then there are, I believe, probably breast coils. But the breasts basically come through these orifices, and then that kind of, in the same way that compression helps you, stretch out the breasts, the kind of the prone positioning helps you kind of release that fibroglandular tissue. So kind of going through what our sequences look like. So this is our T1 with and without fat suppression. So this is our pre-contrast images. We have a patient with implants here. And you can see we have our fibroglandular tissue, and then our fatty tissue that gets subtracted out on the fat suppression. We use Vibe for our fat suppression at Wake Forest. Basically, our T1 weighted pre-contrast images, especially the ones without fat set, are particularly useful because they have the best spatial resolution. So especially if we're looking at our axillary lymph nodes, this is really the best sequence for that. We are also have to report a breast density, and we use our T1 weighted images, pre-contrast images, to give our measure of breast density. Also, if lesions are T1 hyperintense, we can also we can tell that they might be something that has blood, like a cyst that's T1 hyperintense, could be one that has blood or proteinaceous debris as opposed to simple fluid. And then fatty lesions also are bright on T1 as well, of course, you may know. Then we have our fat saturated T2 weighted images, which of course shows our high fluid content lesions. In breast imaging, what T2 weighted images generally tend to show you lesions are more likely to be benign. If a benign lesion completely corresponds with enhancement, then you can be more confident that it's a benign entity. So things that you might be dealing with that are T2 hyperintense include fibrocystic disease. Fibroadenomas are usually T2 hyperintense. Lymph nodes are usually T2 hyperintense. And these are the things that are going to be masses that are going to show on your post-contrast images that you're really going to have to troubleshoot on T2 weighted images. So you see an enhancing mass, and you go back to this T2 weighted image, and you have to ask yourself, do I feel like this mass that is T2 bright, does it match completely with my enhancing mass? And how confident am I that it's one of these two entities? Now, I say this, that T2 hyperintense lesions are more likely benign, but if you go to lectures, case conferences, or cases that we've had internally, and you look at known cancers, plenty of them also have been T2 bright. So, it's also like just because it goes with it, could increase your level of confidence, but at the end of the day, it's still a bit of a judgment call. And then, of course, there are going to be cancers that are T2 hyperintense. So mucinous carcinomas are known for being T2 hyperintense with a rim-like or having heterogeneous enhancement. And then necrotic tumor, so areas of T2 hyperintensity and known in a tumor. So that's why I say that it's suggestive of a benign lesion if it corresponds completely with enhancement. If you have areas of T2 enhancement that are less than the whole mass, then you have to consider that you could be dealing with like a mucinous carcinoma or areas of necrosis within the tumor. And then kind of this is what our diffusion weighted images look like. I'm not going to spend too much time on that, but basically this is probably one of the prettiest diffusion weighted images I have ever seen. Most of our diffusion weighted images do not look like that. Like I mentioned earlier, you need like really good field homogeneity to achieve good DWI images in the breast. But basically, people are trying to investigate using it for cheaper and faster screening MRIs. And then this is our post-contrast images. So this is on the left, we have our T1 Vibe pre-contrast, our T1 Vibe post-contrast, and then our subtraction images. So you can see that on these subtraction images, the heart subtracts out, the liver or the heart enhances, the liver enhances, but this mass that was intrinsically T1 hyperintense subtracts out and is dark on the subtraction images. We reconstruct all of our post-contrast subtraction sequences on a maximum intensity projection, our MIP. This is what we can how we can easily look at everything at once, and you can see on this patient, this is kind of what a negative MIP looks like, and then this is a patient who has areas of suspicion on both breasts on these MIP images. And then talking about our dynamic enhancement. So basically, the reason we do multiple post-contrast sequences is that the idea is that a malignancy is going to have a lot of microvasculature, same idea as with hepatocellular carcinomas, so that they're just like with HCCs in the liver, they're going to take up contrast more quickly than the surrounding breast tissues, and then it's going to lose that contrast more quickly. So we call that type 3 enhancement or washout enhancement. We basically look for kinetics that peak and then decrease in the late post-contrast period. We also, as opposed to type 2 kinetics, which rise and then hold steady in their enhancement, and then progressive is going to be constantly increasing in enhancement. Type 1, type 2, and type 3, or type 1 and type 2 are considered more likely benign, with type 2 being intermediate suspicion. But on the other hand, we do always teach, this is kind of our motto with kinetics, which is that morphology trumps kinetics, because just like I mentioned, you will always find cancers that are T2 bright. You will always also find cancers that are completely progressive in their kinetics. So if a lesion has suspicious morphological features, you're still going to call that suspicious even if they're completely progressive. On the other hand, if you are not sure about a mass, you think that it's T2 bright, but then its kinetics show progressive or plateau or washout kinetics, that might tip you over and say, I feel like this should help me. This should prompt a biopsy. Also, kinetics is helpful if in patients, you've all seen patients with numerous benign masses, numerous masses that could be fibroadenomas. If one of them demonstrates different kinetics, that also helps us, kinetics helps us in those situations. And this is what our kinetics, this is how we look at kinetics in the breast. So this is our post-contrast subtraction images, although I think this one, post-contrast subtraction images. Up top is, I told you we use Dynacad software to look at the kinetics, and so in every voxel, Dynacad basically has created this plot in that voxel. And so if it is progressive, you can see this line going steadily up, up, up. It's going to assign it a blue color. So all of these areas of blue are going to be progressive kinetics. If it's a plateau, if these, you can see the variation in time points. This one's 3 time points. You can see the plateau kinetics, and it's going to assign that green. And then for washout kinetics, so you can see on the last one, it goes under this line. It's going to be washout kinetics, and that's going to be given a red voxel. So you can see in the breast right here, this lesion is assigned red, so that's washout. Plenty of lesions can have mixed kinetics. I mean, you can see that this one and this one doesn't even look that different on the plot. So there are plenty of lesions that the computer is going to assign some voxels green, some voxels red. I think that I would still consider this suspicious. And then, of course, the heart is going to be all red, because ideally contrast leaves the heart very quickly. So that's basically why we do multiple post-contrast images to give us this information. Now, I do want to touch base on something that we don't do, but that many private practices have started doing, which is called an abbreviated breast MRI. The idea is that, breast MRI is a very costly and time-consuming examination. So many practices out there have offered what's called an abbreviated breast MRI, which is that they remove some of the sequences and try and be diagnostic in as few sequences as possible. The most common thing that they do remove is that dynamic post-contrast. Instead, they opt for a single early contrast, so you're looking for this time point only. And then some of them omit fat saturation and just use the post-contrast image to subtract fat as well. So there are efforts to make breast MRI a lot more efficient, accessible, and affordable to patients. I'm just going to touch briefly on our implant protocol. So this is what we do for non-contrast breast MRIs, as well as for patients who have had mastectomies and implant reconstructions. We also want to make sure we're assessing their implant on our breast MRIs as well. So we give them a T1 weighted axial and a sagittal without fat saturation. We do T2 weighted fat sat axial and then a T2 weighted silicone suppression axial. The idea being that the implant ruptures that are clinically silent, of course, are these silicone implants. The saline implants would deflate immediately. And so you want to also be looking and making sure nothing in the breast is free silicone. So that's why you do these silicone suppressions and then these water suppressions. And then we also do coronal and sagittal water suppression T2 weighted images as well. And this is kind of what our implant-specific sequences look like. So this is our T2 stir with silicone implants. You can see that these implants with saline implants, you can see that these saline implants are T2 bright. And then on our water suppression images, these saline implants are satted out. And then on our T2 stir, we have our water suppression images. And then we have here with a silicone implant, our water suppression images. And then our silicone suppression images make the silicone implants darker. Moving on, I'm going to talk about our BI-RADS lexicon for breast MRI and how we describe things that enhance. So the first thing that that BI-RADS says that we have to report is a background parenchymal enhancement. We call it BPE for short. And because breast tissue is extremely dynamic tissue, it can take up contrast very readily, and it's very patient dependent. We try and optimize our breast MRIs for the menstrual cycle. I'm forgetting off the top of my head, but somewhere around 7 to 14 days after the menstrual cycle for minimum background parenchymal enhancement. I apologize, I might have gotten that wrong, but something you guys can Google. We report that, so it can vary from minimal to marked background parenchymal enhancement. And so showing you examples of each of these levels. And unfortunately, trying to decide if something is background parenchymal enhancement or a suspicious finding can be a difficult task. So this is kind of how we describe things that enhance. There are 3 broad categories: focus, mass, and non-mass enhancement, with descriptors for each of them. And I'll try and be quick through this so I can go through our cases. The first thing is focus. This is actually something that is going away, so I won't spend too long on it, but it used to refer to something that is less than 5 millimeters. But people have decided that that because they don't have a minimum size threshold, that if you feel like you can describe features, you feel like it's a mass that's less than 5 millimeters, you should still call it a mass. People find that's not a useful term anymore, so we're moving away from focuses of enhancement. But you might see people still using that term. You might see old reports still talking about foci of enhancement. So moving on, we'll talk about masses on MRI. So we define a mass on MRI as a space-occupying lesion with convex borders. We describe them with 3 different shapes: oval, rounded, and irregular. So here are some examples of those. Really, these are the same as on ultrasound or mammogram. Oval, round, and irregular. You talk about those on ultrasound and mammogram as well. Kind of looks the same on all 3. So I'm going to talk about our margins on MRI masses. So we have circumscribed masses and masses that are not circumscribed. And so circumscribed, of course, we describe that as a sharply demarcated transition throughout the entire region. Spiculated is going to be characterized by lines radiated from the mass. I mean, everyone here should know what spiculated means. We see it all the time in other parts of radiology. Irregular is kind of a different term in MRI. And I think it trips up trainees a lot because in ultrasound, we have irregular shape, but we do not have irregular margins. In MRI, we have irregular shape and we have irregular margins. We don't have some of the other descriptors like angular, microlobulated. If they ever let me on the BIRADS committee, I'll sort that out. I think it should all be the same. But basically, irregular means uneven or jagged edges. It's going to be something that looks like this. It's not circumscribed, but it's also not quite spiculated. And then we also describe the internal enhancement. We have homogeneous and heterogeneous. And then there are a few more breast-specific terms like rim enhancing, and then a specific pattern called dark internal septations. I have an example right here. This is just something that suggests it's more likely a fibroadenoma. You see that this is an enhancing mass, but you see these thin little lines internally. That's something, when I see that, I'm more confident this mass is a fibroadenoma. Moving on to non-mass enhancement. So I think this is kind of something that you're more likely to see only on breast MRI, although non-mass is starting to be used as a descriptor in ultrasound as well. So with non-mass enhancement, it's going to be something that enhances, but you can't call it a mass. It's going to be something that stands out from your background parenchymal enhancement, but it doesn't look like it occupies space. It doesn't look like it has convex borders. These usually don't have correlates on your T1 weighted pre-contrast images, and so you usually designate those as non-mass enhancement. So we describe non-mass enhancement with two descriptors. The first is going to be the distribution. And fortunately, the distribution is the same as what we use for calcifications on mammography. So there's nothing new here. And just like with mammography, or I guess the main new thing is we call it focal non-mass enhancement, and so we don't have group non-mass enhancement, of course. Focal is going to be less than a quadrant and has fat or glandular tissue interspersed. And focal, linear, and segmental are going to be the ones that could be suspicious. And then we have examples of linear and segmental non-mass enhancement here. And then for internal enhancement features, we have homogeneous and heterogeneous internal enhancement. And then we have two descriptors that you only see on breast MRI, which is going to be your clumped non-mass enhancement. So it's going to be, the official description is cobblestone enhancement of varying shapes and sizes with occasional confluent areas. This is kind of an example of cobblestone enhancement. It's a little bit random. And then we have clustered ring enhancement. These are thin rings of enhancement clustered around the ducts, and that's going to be something that's going to be suspicious for DCIS. So you see on this image, you have this little a little enhancing circle, and then inside you have this black dot. So that's going to be the duct, and then this is going to be periductal enhancement. That's what clustered ring enhancement represents. All right, and then lastly, I'm going to talk about our cases. Show you guys a few cases, what these things look like. So case number one, this is just a finding in the left breast. We have a mass on our T1 weighted fat sac images. Our T2 weighted fat sat images shows that this is hypointense, and this does not enhance. This is the look of a complex breast cyst. Figure I just show that there, something benign that might catch your eye on a T1 weighted image. So a complex, or sorry, I really should say complicated breast cyst. That's my bad. Non-enhancing T1 hyperintense mass. It's got these circumscribed margins. This is a benign finding. The important thing is that on your post-contrast images, you want to make sure these don't have a nodule on the wall. That might indicate that there's a papilloma you have to check out more, or you have a malignancy that's cystic. Just moving on to the next case. The first few are going to be quick. This is a finding in the left breast. So you have this is what it looks like on the T1 weighted pre-contrast fat sat images. You do see that internally we have some T2 hyperintensity, but most of this enhances on the T1 post-contrast. You also have the susceptibility artifact right here. So this case turned out to be an invasive ductal carcinoma. This was actually an MRI done on someone after a biopsy where we were looking at either an additional site of malignancy or we were looking to track the response after neoadjuvant therapy. So this is a mass that we would describe as I would call this a round mass. I would call its margins irregular margins. I don't think these are circumscribed, but they're also not spiculated either. And then it's heterogeneously enhancing because we got this dark area internally. And then also kind of, I was mentioned, again, just hammering home the point that for T2 hyperintensity to suggest benignity, you really need it to encompass the whole mass. And this internal T2 is probably just the necrotic area. This patient proceeded to get a lumpectomy and chemoradiation therapy. And then moving on to the next slide. For case 3, we have this finding in the left breast on a post-contrast sequence. You see a little bit of motion artifact there. So really minimal or mild background parenchymal enhancement. You don't see much enhancement in these tissues, but then this line in the inner breast really stands out. So this is what I would describe as linear non-mass enhancement that's probably internally heterogeneous. I believe this part would be heterogeneous as well. So because it is linear non-mass linear non-mass enhancement. This warrants a biopsy. And this was actually a patient that got an MRI to evaluate for Paget's disease of the breast. So we already are very suspicious of this patient having a malignancy in their breast. And so this patient showed I believe actually that this was considered non-mass enhancement as well. And I'm not showing it on this image, but this was probably asymmetric from the other side. And so these were probably 2 foci of DCIS in this patient, and so she underwent a mastectomy. So DCIS on your MRI usually presents as non-mass enhancement that's linear or segmental, and then you often clump internal enhancement, which can be heterogeneous. All right. And moving on to case 4. So this is one of the cases I put in here to kind of show you a clinical scenario where MRI was extremely valuable. So this was a screening mammogram that I read with a resident. So this was a screening mammogram. You know, what stands out to you is this very large left axillary lymph node. This is our CCN MLO view of the left breast. So we called her back for this lymph node. Really didn't see much in the breast to call back. So we did an ultrasound showing this very vascular left axillary lymph node, and then the biopsy was done, and the biopsy came back with invasive ductal carcinoma. And so so knowing that she has a breast malignancy, we did a breast MRI, and then so here I'm showing you the post-contrast subtraction images for this patient, and then here's the MIP of both breasts. And then you can see what easily stands out is this linear, I would call this linear clumped non-mass enhancement in the inner left breast. And you can also see that lymph node on the MIP images, maximum intensity projection. Just putting the mammogram side by side in retrospect, this is the area that that was the malignancy, and it just really didn't stand out from the rest of the breast tissue. Looking back on this patient's priors, this was something that was a very slow change over many years that just didn't catch people's eye when they were looking at it, myself included. And so this is something that really stood out on the MRI, and it was really helpful in figuring out where in the breast this malignancy came from. We did an ultrasound on her and kind of showed this correlate. And so one of the things we do on breast MRIs is that if you feel like your initial assessment wasn't targeted enough, or that the MRI is, that if you had the MRI side by side, you could find an area on ultrasound or on mammogram. We do oftentimes send patients back for what we call an MRI-directed second look ultrasound or an MRI-directed diagnostic mammogram. And so, which helps out a lot. Because even though you can do biopsies under MRI guidance, it really, I tell patients, it's the most unpleasant experience we have to offer at our breast department. So we generally avoid if we can. And so in this patient, rather than put her through an MRI guide biopsy that could have been avoided, we tried to find this on ultrasound, and we did find this area in her inner breast that measured about 2.4 centimeters, correlated very well with her breast MRI, and ultimately she was biopsied, and that did turn out to be the primary. So this is just to highlight the use of MRI in detection of occult breast malignancies, because it's so sensitive, and it also gives you physiological information that you don't get from ultrasound and mammogram. It's very effective for see as something you might have missed on your mammogram or ultrasound. This patient ended up undergoing. So first of all, this image I'm showing you right here is a follow-up after neoadjuvant therapy on this patient. So we ended up biopsying the breast, biopsying the node, finding that this patient had IDC at both sites. She got neoadjuvant therapy, which then she got a follow-up breast MRI. On this follow-up breast MRI, we showed that there is really no enhancement in this area. And then when she got a mastectomy, they noted no residual cancer in the breast or the lymph nodes as they removed. So good success story for us. And then for case number 5, so this is a patient who had a mammogram, a diagnostic mammogram for an area of palpable concern. This was her most recent mammogram in August of last year, and this was her mammogram June of this year when she felt like she was feeling something in this area. And so she got a diagnostic mammogram and ultrasound, and we felt that on our initial assessment that this patient, that we were kind of concerned about this asymmetry underneath the area of palpable concern, and that we did see a mass in this area at measuring about 8 millimeters. This patient was biopsied, and she was found to have an invasive lobular carcinoma. So at our institution, we recommend an MRI whenever we see an invasive lobular carcinoma or an invasive ductal carcinoma with lobular features. Not every surgeon takes that recommendation, but many do. So this was her breast MRI, and it turns out that she has a very large area of enhancement, of non-mass enhancement in her right breast. And though this is technically regional, of course, none of us are going to call this benign. This is just highly concerning for multicentric malignancy. And so you go back to her mammogram. This was probably when we were initially looking at her mammogram, it's in retrospect, you can tell that, all of this tissue is distorted. This is suspicious, but we've all seen fibroglandular tissue that takes on this configuration somewhat, and the MRI really establishes without any doubt that all of this tissue, all of this breast tissue is invasive lobular carcinoma, rather than just this area we were looking at or just that area we found on the ultrasound. I just wanted to highlight that MRI is very useful in invasive lobular carcinoma, and it's most accurate in size estimation of ILC. There's some literature that says that maybe we overestimate with ILC, but overall, I think many people think that feel that MRI is best in this situation. And also, with invasive lobular carcinomas, we do have a higher rate of finding a contralateral malignancy or a multicentric malignancy. So, and so MRI that's why we recommend MRI, to find these additional sites of disease we weren't suspecting, like in this patient. And so, we advocate for an MRI after every ILC diagnosis. This patient ended up undergoing a bilateral mastectomy, and her estimated size of the tumor in the right breast at path was 12 centimeters. And then for this was just the last case I wanted to show you, which is just like what I've mentioned throughout that we do non-contrast MRIs to look for implant rupture. This is kind of what an implant rupture looks like on a breast MRI. We have the capsule and then we have the wall of the implant. And so this is what a normal implant looks like. They have you don't see any lines in this implant. Now, usually you do see something we call a radial fold, which is like the two walls of this implant approximated and folding inward. But then on the left side in this patient, you see a line that has signal on both sides, and that usually prompts us to suspect an intracapsular rupture. This also is another finding that we call a keyhole sign. If there was not signal inside this line, this is what a radial fold would look like. But because we have signal inside, that means that it's you have inside of the implant, and then that signal is a silicone outside of the implant, and we know that to be silicone because it follows silicone on these silicone suppression sequences. And then we also, use these sequences to look for extracapsular implant material, and then treatment usually requires that these implants be surgically removed. And so that's all I had. I hope I did a decent job with the time management, and think it'd be a good time for any questions.
All right. Thank you very much, Dr. Nui, for such an informative and very straightforward lecture. I invite everyone to share their questions and any inquiries. Okay. All right. So meanwhile, while we're waiting for the questions, I just have one question to ask Dr. Nui. In your institute, do you use the Spallgrass sequence as well for a better interpretation?
Oh, sorry, what sequence? I think that word cut out.
The Spallgrass sequence.
I'm not sure I'm familiar with that term.
The fast-spoiled gradient echo sequence.
I don't think we use that for ours. Or if it is, we use it or if it is, we call it by a different name, and I'm just not familiar enough with it. Yeah,
I think so. I think it differs from the company. Okay, one question for Dr. Nui. What is the difference between complex and complicated cysts? They appear to be different since you mentioned them in particular.
Oh yeah, and so this is as a brief thing. I'm not too familiar with this community, but do most people also use the BI-RADS lexicon, or is that more of an America specific thing?
As far as I'm concerned, we do tend to use the BI-RADS lexicon.
Okay, yeah, and so I just it's more of a breast specific thing where things that almost every other radiologist would call complex, the BI-RADS just call it complicated cyst, and it's to distinguish it from more of an ultrasound or a finding of a complicated solid and cystic mass, and so that's why it's a complex breast cyst and or complicated breast cyst and a complex solid and cystic mass. It makes no sense. I don't think I don't. If they ever let me on the BI-RADS committee, I'm going to change it to complex cysts. I think it's too confusing for patients that don't do breast all the time. But so to answer your question, there's really not a real difference. It's just about semantics, academics, and terminology.
Okay, thank you. Another attendee has asked if you can go through the BI-RADS again.
Oh yeah. So I'll just put this. I'll go back to that slide. And also, if you look up the American College of Radiology MRI BI-RADS lexicon, they have all of these terms in like a chart. This is just how I like to organize them. So you have the three broad categories of things that enhance your focus, your mass, and your non-mass enhancement. And then, with masses, we describe the shape, the margins, and the internal enhancement. And then for non-mass enhancement, you describe the internal enhancement distribution. I think there are a lot of parallels to this with how you describe things on mammogram and ultrasound, like in terms of shape, or like with the way that you describe distribution on non-mass enhancement. So hopefully, it's pretty intuitive, not too much of a jump. And I hope I tried to make an effort to make a point of the things that you don't see in ultrasound and mammogram. But yeah, I'll just leave this slide up. But you can find these terms with the with the American College of Radiology.
Okay. Another question. Apparently, an attendee finds mass versus non-mass enhancement very confused to differentiate on imaging. Would you give some tips on how to differentiate them?
Yeah. So I think that the main things is do you think the margins are primarily complex, and also do you think that it occupies space? And for me, one of the things that I decide that helps me decide if it occupies space is I go to the T1 pre-contrast images. If I feel like on the T1 on the T1 pre-contrast images, I have a definite correlate, I'm more likely to call it a mass than a non-mass enhancement, because to me, if it's on the T1 pre-contrast, and it's occupying space. That being said, though, on the other hand, the great thing about breast imaging is that we're only looking for one thing: breast cancer, right? It's either cancer or it's not. And if you think that it is suspicious for malignancy based on its features, then you biopsy it anyways, right? So fortunately, if you see something that's suspicious, whether or not you call it mass or non-mass enhancement is kind of up to you, as long as the management's the same either way if it looks suspicious. Now, that being said, if you are, sometimes you might be asking yourself a question: is this an irregular mass or is this non-mass enhancement, right? That's where I think you might be having trouble, like, because if it's non-mass enhancement, then maybe it's one of these more benign areas of non-mass enhancement. If it's an irregular mass, then it's definitely suspicious. And for that, I think going to the T1s might be helpful. Sorry, I think you're muted.
Sorry. Okay. Another question is, someone is asking whether you prefer STIR or T2 fat sat.
I think STIR is what we use for our fat sat. I mean, I like the STIR. I don't think I've read it with anything else other than STIR for the fat sat, but I'm sure other T2 fat sat techniques are fine.
Okay. Before going to a question on mammograms, a question related to MRI is: how big is dynamic study for you to decide whether a lesion is suspicious or not? Did you call them mostly based on morphology? I actually think you answered that, but if you want to elaborate further.
I would say I use kinetics about 10% of the time. This is a little bit of a joke with the trainees, but I tell them, like, if you use the kinetics as a tiebreaker, right? Or if you see a mass and you can use kinetics as a reason not to biopsy it if you don't want to biopsy it, and you can use kinetics as a reason to biopsy it if you want to biopsy it, right? But morphology should be what you're making your decision on 90% of the time. And so the kinetics are really to help you when you are on the fence about it, or also if you have numerous sites that are standing out to you. You can't biopsy 10 different things, right? So you can use kinetics to say, okay, I want to biopsy one or two things that are most suspicious, and these are the things that might have progressive or washout kinetics. And if those are okay, we can just watch the other areas or something like that. Those are the situations where it really comes in handy.
Okay, thank you. That was an excellent answer. Another question is, how would an intraductal papilloma appear on breast MRI?
Yeah, so intraductal papillomas, you generally see that as an enhancing mass. Sometimes and the thing about intraductal papillomas, and I think it kind of gets into this mass versus non-mass enhancement. I think they're often very small when we find them on MRI, and they're often inside the ducts. So sometimes they could look like linear non-mass enhancement, or they could look like a mass. But yeah, usually they would be like they would be a small enhancing mass. And then so you might see dilated ducts associated with them. And I didn't cover this or show images, but dilated ducts do show up. You can very easily see dilated ducts on your T1 and T2 pre-contrast sequences.
And related to your previous question, someone has asked about how about kinetic curve? Is it useful?
About what? Sorry.
The kinetic curve, the
kinetic?
dynamic contrast enhance the kinetic curve that you showed, 1, 2, 3.
Yeah, I do think it is. I do think it is quite useful, especially with breast MRI being such a sensitive modality. It really does bring out a lot of, you do have a lot of findings in the breast, and it is helpful to have something to help you parse it out even further. Now, that being said, there are people looking for ways to get around it for a reason, right? Because it is a big limit, because cost and accessibility is such a huge limitation of breast MRI. There are plenty of people out there who feel like if you can offer breast MRI to people if you the kinetics, they're looking for ways to do that. Personally, I do find it to be useful.
And another question was, how sensitive or specific is abbreviated MRI in diagnosis of breast disease?
That's a good question. I'm not familiar with the literature on that, especially because I don't do it. I also am not sure if it's been around long enough that there is good data on it to begin with. But yeah, I'm sorry, I'm not well versed on that data.
All right. Okay. And one question was not quite related to our topic, but while describing mammograms, is it an obligation to give a particular pathology as a conclusion, or can you tell whether it's probably malignant or benign?
We generally never give specific pathologies. I have seen some private practice physicians maybe speculate on a benign entity for a suspicious finding. Like they might say, or they might speculate like benign and pathologic side by side. Like they might say DCIS versus like I don't know, fibroadenomatous change. But the way we practice is we just kind of say whether things are suspicious or not. Yeah, when I was training, I think it applies in this scenario with like our older residents used to share something like, you can only be wrong, meaning like there are things that you can say where if you're right, it doesn't change anything. Like if you're right about it being DCIS, it doesn't change anything. You were going to biopsy it anyways. You were going to prove that it was DCIS anyways. But if you were wrong about it, you just look like you might not know what you're doing. So things like that, if it's especially in the breast where you're going to biopsy it anyways, there's so much overlap between benign and malignant entities and their appearance. Oftentimes, I just feel like it's something that either you're right and it changes nothing, or you're wrong and you look bad.
All right, I think we're almost out of time. We have two last questions. The first one says, how do you pick up multifocal multicentric lesions in known cancer cases that may present as non-mass enhancement when there is moderate or marked background enhancment?
Yeah, and so that's the kind of thing why I put up that little meme. It's very tough to pick out non-mass enhancement from background. It's the kind of it's why like interpreting MRIs is so hard, and why like I think the specificity on the MRIs is so frustrating. And at the end of the day, what I recommend to trainees is that they take a step back and just look for things that stand out to them. At the end of the day, you've studied very hard. You've looked at many images. Your intuition and or like just one neuron in your brain firing, hey, this area doesn't look great to me. That's worth something, and you just gotta think through every area that stands out to you. When you like look at that MIP, you take a step back, and if nothing stands out to you, that means that you might just be dealing with that background parenchymal enhancement. But I admit that it is very tough. I'm not even sure I do a great job of it.
Oh, I agree with that. And another question is, do you have a checklist or an algorithm when you approach a breast MRI? And the person would like you to share it with them.
Yeah, sure. So when I go through breast MRIs, I think the first thing that I do is look for the things that could really embarrass me. So like, the liver cysts, the axillary lymph nodes, internal mammary lymph nodes, lung nodules, stuff like that. And usually I look for that on the I look for that on the T1 and the T2 pre-con images. And then after that, I kind of go through, I go through the T1 precon to get a sense of the fibroglandular density, as well as the and then the T2 for like kind of for any cysts that for any like cyst lesions or anything like that. And then after that, I really just really drill down on the post contrast sequences, and that's going to be like 80-90% of your interpretation time, really just thoroughly going through every part of the breast. And people do it and have different ways of scanning the breast. I think the way that I do it is I just kind of go left to right, each breast in thirds. Like I'll kind of go like, if I'm starting from the right, let's say, just pretend there's the right breast is the left breast. I would just go outer breast. I would scroll through it completely. Then the central, scroll through the post contrast completely. Then inner, and then I kind of go through it again. And for that, I focus on the first post contrast, because that's going to be the part that that's going to be the area where your malignancies are going to enhance in a way that's different than your benign entities, right? That's where that washout peaks. And then I kind of I kind of just go through the other post-contrast sequences as well, but I go through them quicker on a subsequent times. And then I look at the Dynacads for enhancement, for the kinetics last.
And the very last question is, what is the Linguini sign on silicone implants on breast MRI?
The Linguini sign, yeah. I didn't go too much into implants, but Linguini sign is basically, go to the last slide. So basically, linguini, and this may not be but linguini is basically like a noodle, in case might not be familiar, because, very diverse culture. It's not Eurocentric. So linguini is like a pasta. So you just imagine it looking, these lines, if they lay flat like a noodle, that's what they mean by linguini sign. So imagine if there was a lot more fluid around this implant and this wall was collapsed down. That's what a linguini sign is.
Okay, I think that was the last question. So if there are no more questions, I will end the session. Thank you very much, Dr. Bowen, for such an informative lecture. And thank you to all the audience who have contributed to the questions and attended, as well as Dr. Nat and Dr. Deeta, as well as our IT. Now I hand over the session to Dr. Nat, who will do a bit of housekeeping. Thank you.
Yes, Dr. Pema and Dr. New, if you want to leave, please do. I'm gonna speak only 1 minute here. Don't want to waste anyone's time. So it is almost the end of the year, and after this lecture, we will have 2 more lectures, and that will be it for this year. So the next lecture will be this coming Sunday. It is MRI staging of cervical and endometrial cancer by Dr. Surabi. So, and one more thing is we are approaching the end of the year. So we will have a meeting among educational committee to set up the topics next year. If any one of you who are here hear me and you see my email address on the screen, any topics you want to know, you just email me and I will bring that up in the meeting to integrate everything together. So next year we will have another 20 lectures like this, like what we are doing. Please feel free to email me any topics that you want to hear, because I really want to hear from you guys what you really want, not what I want you to hear. I want you to hear what you want to hear. So email me at that email address. And we'll see you on next Sunday. Thank you for joining us today, and have a good night, everyone.